والدكتور عادل المنتصر. فإن شاء الله هنبدو Dissection. كل محاضرة حتكون 15 minutes وخلوا ال questions to the end. دكتور خالد اللافي حيقدم دكتور إبراهيم الآن.
بسم الله. It's my honor to start the second intervention session. We collected a very nice collection of speech. This will be very complex PCI cases, and we have eminent speakers. Every speaker has 15 minutes. We try to cut it short because the questions, because we have another session at 1 o'clock. So please, every speaker, stick to the time. It's my honor and pleasure to introduce the first speaker, Dr. Ibrahim Badr. He's an associate professor, Division of Cardiology, University of Alberta, is Canada. He's well known to most of us. He's done a lot of workshops in Benghazi, Sabha, Zlitin and Thrombus. Dr. Ibrahim, the stage is yours. He's going to talk to us about spontaneous coronary artery dissection, diagnosis and management.
السلام عليكم ورحمة الله. تقدم بالشكر للمنظمين لهذا المؤتمر وأعضاء الجمعية، وشكرا دكتور خالد ودكتور عبدالغني. هذه will be a quick review of spontaneous coronary artery dissection. Nothing to disclose regarding this talk, and we'll cover definition of SCAD, presentation, clinical presentation of patient with spontaneous coronary artery dissection, epidemiology, pathophysiology, evaluation of those patients, and we'll come to treatment and management at the end. So this is a patient actually we saw here in Libya, and so this is 42-year-old woman who's not known to have any cardiac risk factor, presented with chest pain, diagnosed initially with non-ST elevation, acute coronary syndrome, and found to have high troponin, started on medical treatment, and then she had an angiogram. Can they play the video here? Or? Anyway, this is so this patient, after appropriate medical treatment, she had an angiogram, and as we see here, there is obvious obstruction or flow limiting disease involving the left anterior descending artery. This patient was treated medically, diagnosed as possible SCAD, even though we didn't have image to confirm that at that time. So what's the definition of SCAD? SCAD, it's a tear in the epicardial coronary artery, and usually which is not caused by trauma, intervention, or atherosclerotic plaque rupture. And it can cause, an intramural hematoma, and we can have false lumen in the coronary artery, which will limit the blood flow of the coronary flow and can cause myocardial ischemia. And it's not common, but still a cause of acute coronary syndrome in young females with no known vascular or cardiovascular risk factor. How do the patient of SCAD present? They can present with acute coronary syndrome, either STEMI or non-ST elevation myocardial infarction, can present with arrhythmia, ventricular tachycardia, VFib, congestive heart failure. Some of them we don't see because their initial presentation will be sudden cardiac death. And as we know, the most common cause of acute coronary syndrome in general population is atherosclerotic plaque rupture, leading to supraimposed thrombosis obstruction. But in SCAD is different because there is formation of the intramural hematoma can lead to compression of the coronary flow resulting in acute coronary syndrome. What's the etiology of SCAD? It's not clear. There is no clear one cause of it, but it's thought to be multifactorial and can lead you to sex hormone play a role in that, environmental stress, arteriopathy like fibromuscular dysplasia contributed to its occurrence as well, which is, as we know, fibromuscular dysplasia is non-atherosclerotic, non-inflammatory vascular disease, and usually common in young women, can cause stenosis, dissection, and aneurysm. And usually it can also occur in young women, especially if they are pregnant or taking oral contraceptive pills. Actually, I have a patient who's young. She's only 32. She was missed as anterior STEMI of SCAD, and she had bad heart failure. She's awaiting for a transplant. She presented to the emergency department somewhere in Canada, and she was treated as non-cardiac chest pain, and she ended up with bad heart failure. Estrogen and progesterone can cause structural changes in the vessel wall, which can increase the risk of SCAD. And there's not much data about it, even though some places now have a registry like Vancouver. They have a SCAD registry, which is they have start more than 1,000 patients. So we send our patient there, and it's 15%, like some data show that 50% of patients with fibromuscular dysplasia, we can have arterial dissection, and 2.5% of those patients can present with a SCAD. And the interesting thing is fibromuscular dysplasia had the same histological and angiographic feature of SCAD, which can occur in other arteries, non-cardiac artery. We still need more data for that, involving more patients. And unfortunately, the patient with SCAD, some of them, they have poor prognosis. They can dissect their left main, multivessel disease. They can present with cardiogenic shock, STEMI, and ventricular arrhythmia. And there's some correlation between, possible correlation between SCAD and intense exertion. And as you see from the table, there is a summary of predisposing causes, including fibromuscular dysplasia, pregnancy, connective tissue disorder. We see Marfan and Ehlers-Danlos, inflammatory disease, all of the inflammatory disease from ulcerative colitis to Crohn's disease, SLE, and coronary artery spasm, idiopathic, and there is other possible precipitating stress, as not uncommon to see patients after intense exertion to have SCAD or present with acute coronary syndrome due to SCAD. It's very high in women, and usually in their 5th and 6th decade, and they don't have much of cardiac risk factor, and the SCAD overall contribute to less than 1% of all of myocardial infarction, and we have very limited data for men. And the pathophysiology, as we know, there are 3 layers of the arteries or the coronaries, and usually there is a tear on the intima, lead to accumulation of blood and lead to hematoma, intramural hematoma, which can propagate and block the artery. And there's one study found that the vasovasorum rupture can cause the medial dissection, lead to formation of this, of the hematoma as well, in some cases. How many types of SCAD we have? We have type 1, which usually we have multiple radiolucent lumen. Type 2A, we have diffuse narrowing of more than 2 millimeter, bordered with normal artery proximal and distally. Type 2B, which is also the same, but it can extend to the apical tip of the epicardial artery. Type 3, focal or tubular, which sometimes it's easy to miss or confuse with atherosclerotic plaque rupture. And those shows some of the SCAD times. If you see figure A, it's SCAD on the distal. There's no pointer, but as you see typed over there, the star there is a SCAD in the left anterior descending artery with staining of the artery, which is on type 2A, which is in figure B, which is down there. You see type 2A, and then type C, figure C, which is type 2B, which healed after a few weeks of medical treatment. And type E, or type 3, which is in the figure E there, which is easy to confuse with atherosclerotic plaque rupture. For that, there's an OCT which confirmed the intramural hematoma. And what those patients present with chest pain, ECG changes similar to the other cause of, similar to the other presentation of acute coronary syndrome. They can have warm motion abnormality, and usually the diagnosis happen with a catheter-based coronary angiogram, which usually the first diagnostic procedure. And usually we can see beaded appearance of the coronary artery due to multiple reticulocyte lumen, and we see contrast staining, which shows two lumen on the SCAD sometime. Early angiography is the way to go. Then diagnose, if it's easy to diagnose with type 1. If not, then you go see if this, the appearance diffuse and smooth, then type 3 or not. And sometimes you need OCT or IVUS to confirm the diagnosis with its own risk, and it's costly to do that. So I'm just going to briefly say that's the IVUS and the OCT demonstrate dissection flat intramural hematoma. And usually they have higher spatial resolution than the angiogram, but usually if there is no, we can't make the diagnosis. And this is show the OCT and figure A that there is intramural hematoma with intimal rupture with the ROS. Figure B there is the OCT with intramural hematoma rupture, and the IVZ, as you see the plus sign there is intramural hematoma. This is some advantage and disadvantage of imaging. Of course, they can give us the diagnosis, confirm the true lumen, facilitate stent sizing, coverage of the dissected segment, facilitate diagnosis of potential arteryopathy, but can lead to its cost as invasive, require anticoagulation, possible risk of extending the dissection either distally or proximally. What's the treatment? The treatment of SCAD is usually medical management, and usually those patients become with acute coronary syndrome treated with appropriate medical treatment. Then after the angiogram, then decide about all of those treatment. We'll continue some of them, and there is no clear guideline about the accurate or the guideline direct medical therapy for those patients. It's not uncommon to see recurrent Ehmaid due to that. CT coronary angiogram doesn't have a big role in diagnosis of SCAD initially, but it can be used for follow-up after that. Percutaneous coronary intervention, it's if needed, the patient is unstable or hemodynamically unstable, has ongoing ischemia, then if it's needed like left main or very proximal major artery, then it can be tried. This but like it has its own risk. Not going to go through all of this, but also know that there is could be like worsen the SCAD. There's some suggestion about what to do with intervention if needed for a SCAD. Bypass is reserved for some of those patients who try or BCI failed for left main proximal dissection, very refractory ischemia despite conservative therapy. And even with that, there is a risk of graft failure for SCAD. Patient, medical treatment, anticoagulation, antiplatelet. We start all of our patients when they present initially, then usually recommend to stop the anticoagulation. The antiplatelet are dual or single antiplatelets, debatable, but this is, I think the main thing is just to make sure the patient on beta blocker, there is no ACE or ARB if the patient has ventricular dysfunction. There is no rule statin for SCAD itself. And the other thing is the patient need multidisciplinary team and need more assessment with CT to see if there is any vascular abnormality on the other part of the body. Cardiac rehabilitation is a big thing. Quitting smoking, try to limit their, or maybe sometimes restrict strenuous exercise. And with this, we'll come to conclusion. It's SCAD. We should keep it in our mind as a cause of, or possible cause of acute coronary syndrome in young women with no cardiovascular or cardiovascular disease. For risk factor, PCI is not the first treatment for patients with SCAD. Needed some time for hemodynamic instability, or the patient has ongoing ischemia. SCAD patient will come in close follow-up compared to other coronary artery disease patients. Acute survival is good, still recurrent SCAD is not uncommon. SCAD patient should closely follow up for cardiac event and further prospective study exploring strategy to improve cardiovascular outcome are needed. Thank you.
Thank you very much, Dr. Ibrahim Badr, for this excellent talk. Now we'll introduce our distinguished speaker, Dr. Mehiar El-Hamdani. Dr. Mehiar El-Hamdani came all the way from the US to speak to us about mastering coronary bypass grafting interventions, essential insights and pearls. Dr. El-Hamdani is professor of cardiology and medicine. He's the director of the cardiovascular program at Marshall Hospital, Marshall University. Thank you very much, Dr. El-Hamdani, for being here with us. The floor is yours.
All right, thank you very much. I'm very here سعيد جدا بهذه الدعوة. حقيقة يعني mixed feelings يعني لكن جد يعني شيء مشجع جدا ومشرف في نفس الوقت. والله يا ريت هذا احسن يتكلم هذا. ايوه. طبعا سعدت بلقاء اساتذه واساتذتي وزملاء واصدقاء محمد احميد دفعتي وحنيف الرابطي ما شاء الله عليهم كلها يعني بسم الله ما شاء الله. نحس ان الجمعيه حتكون احسن وتستمر. عندنا شباب ما شاء الله بوزن عملاق يعني نقول لكم عبدالغني باسم من باسم يعني بجد يعني ايمن السمير وعادل ديوب. وين عادل ديوب يعني تعرف وعبد القادر يعني هذا بجد يعني لما نشوفهم نحس ان عندهم طاقه ونحس ان بالحق هم قاعدين صغار لكن بجد بوزن عمالقه في مجالهم. قامات علميه كويسه مشرفه والمفروض ان احنا يعني نستغلوهم استغلال. هيك كلمه استغلال زي ما تبغوا يعني. عموما شكرا وان شاء الله يعني نكون نقدموا برنامج كويس. Very poor, very boring, so I don't have nothing to disclose for this talk. So the scope of the problem about grafts. What's the problem of the grafts? We know as after the bypass graft and after the surgeon done a great job, almost every year there is a decline in the patency of the graft. Actually starts from the first few days, going on first year, 1 year to 5 years, 5 to 10 years, and then 10 years. By 10 years to 12 years, about 50% of the vein grafts are occluded already, or at least has a severe disease. And as we know, redo CABG, it's not as the primary CABG, not in the outcomes, and not even in terms of morbidity and mortality of the surgery, and not even in relieving the angina after redo CABG. So Adel Dubes just came in. I don't think he would love to do a redo CABG on many of his patients. As we are going through this, things to remember that after surgery, mild to moderate imperfection of the graft attachment is normal. This is just an edema. And this is usually lasts for up to 4 weeks. And you don't have to do anything for it. You don't have to look for perfection at that time. And sometimes just between the first 24 to 48 hours, thrombosis can happen. And if thrombosis happen, go to the native artery as much as you can if possible. If not, you can do thrombectomy. If not, you can call the surgeon back to do a revision, which also he will hate you for that. Again, another thing that you might see, a very critical anastomotic lesion. And if there is a very critical anastomotic lesion, don't touch it in the first few weeks. Just leave it alone, and then maybe you revisit again. And even if you revisit again, it's better to treat the native, because that could be a suture line. And once you balloon that suture line, it will be a rupture and you have to put a covered stent. And I witnessed one case like that. Stenotic lesion in the distal anastomosis of the graft. In the early phases, maybe the first year, you can just balloon them, stand alone. If there is no evidence of dissection, they will do very well on the long run. Otherwise, you have to stent like any other arteries. What is the technical strategies? And I just really, if there is one message, it's very clear. Do not listen to anybody. Listen to your tactile feelings, listen to your visual assessment, and listen to the brain. There's a triangle between your brain, your eyes, and what you feel in your fingers. And always do one thing again and again and again. Don't play too much by changing wires, by changing guiders, by changing catheters. A lot of people, they have this fun. I don't think it's a good idea. You are a technician when it comes to doing intervention. Mastering the technique is repeating the same technique again and again and again until it's just lived in you. You can't close your eyes and you're doing it. I can wire without a dye. I really mean it, because I really trained myself to wire without a dye and reach to the end of the apical part of the artery. And anybody can do that. Saying what I'm saying, your goal is really a good support, less contrast, less radiation, and successful task or intervention. So comes to the access side. Personally, I am a right radial access in any procedure I do, in about 98% of the time. But everybody, and even the literature support for graft study, is a femoral access. If after that you have the left radial, then the right radial. Sheet size, I'm always 5 French size, almost, except if I'm going to do a kissing balloon, kissing stent, stuff like that, I go with 6 French. But again, for grafts, almost the consensus, you should go with a 6 or a 7 French. And then, choosing the guide catheter. I play with whatever catheter I can. I can bring a hose from my backyard, as long as I know what to do with it. So don't worry about, it has to be an air, it has to be a multi-purpose, it has to be, all those things are important, but the most important thing, what you are used to, how you got trained, and what you really like to do all the time, and repeat again and again. I can't emphasize enough about repetition of your method of work. This is just like I'm showing off. This is a right radial. You have engaged to all the grafts and the lima, and you have a picture, a nice pictures from the right radial, 5 French catheters and sheet. So technical strategies, can use IVUS, can use OCT when you are dealing with a degenerative vein graft. You can, but you have to ask yourself why. Number one, using any tools, you're increasing the risk of debris, you're increasing the risk of sending a lot of junk down to the microvascular bed. So why are you using it? Number two, if you're going to tell me for sizing, sizing is a mistake in the graft. You should not base your stenting in a graft by sizing, and we will talk about this a little bit. OCT, I can see a little probably benefit in some cases. For example, if you have a non-STEMI in a vein graft studies, you have 2 vein grafts, they have both of them about 70% of blockage. So which one is the cause? So OCT has shown that in that scenario, if you do an OCT, you can see really a thrombus that you could not see by angiogram, but you can see it really clearly during that test. As we said, how about FFR and CFR? There is no validation of any of these methods in the graft studies. But we are using the native artery to really apply for the graft studies, and it is valid. A lot of people, they go with, for example, if it's 0.85 FFR, considered to be physiological causes. I don't know where validation is, but it is a common practice. I would say if your FFR or IFR is abnormal, go ahead and treat as the native. If they are not abnormal, meaning that more than 0.80 or more than 0.89, then you can just use your own clinical judgment, because nobody will fault you for doing otherwise. When you talk about the internal memory artery and its territory, the problem usually either you need a PCI in the native artery, the LLD itself, either at the anastomosis or distally. But rarely you can have a Steele syndrome. And Steele syndrome could be in the subclavian artery itself, and you just stent the subclavian artery, or could be a prominent intercostal artery. The surgeons sometimes, they try to clip all of them, and sometimes they clip all of them. But if there's a small branch, after a few years, that small branch will develop to be a larger intercostal branch that could make a Steele, phenomena. And then the last thing is, and I've seen a few cases, a lima to the PA artery fistula. So we're going to see the first case. So this is again, a right radial, total LAD, and then, on using a SIN catheter, it's a carotid catheter to get the LAD to the lima to the LAD. And as you can see, there is a severe disease after the touchdown in the LAD. Now I'm using a carry right guider. The carry guiders are very soft and slippery guiders. It's a 5 French, so I put the guider and I really blindly wire the lima if I'm doing it from the right side. Once I wire, it's easier. You can use a balloon for support to wire better. And then once the wire is down, as you can see, this is the lesion. Now, next, ballooned after ballooning. Of course, it's not in the lima itself. It's below. I have to commit to stenting, and I stented that successfully, I believe so. Yeah, good thing. And then we move on with a good result. This last picture is very important. Why? Because whenever you do, whether it's a femoral, left radial, right radial, you have to check on the ostium of the lima, whether you created any dissection or not, in any case that you do for the lima engagement. Now I'm going to go to the next case. So I'm going again right radial. It was very difficult for me, but here you can see maybe an intercostal branch over there prominent. So I could not wire from the right side. Now I wired from the left side. 5 French, regalia wire, went through, and then next thing, you can see the catheter going right away. I don't know if you have a pointer. The catheter is placed over here, and then I'm sending my coils to the mid segment. So this is very important. When you coil the intercostals, not like anywhere else, try to start from the center coming back. Avoid to be closer to the ostium, because there is a chance that could be a little lentier, and then your piece will be out. The only solution for that you have to really put a stent to seal it. I mean, this is another problem. You don't want to do that. So once you do that, and as you can see, only in the center, the whole branch is occluded completely, and there's no more Steele phenomena with this. This is a very neat case just a few months ago. So there is a lot of fistula between the lima and the PA artery, and you can see it in different views. And you can see, and this is really crazy, but I like deep guider engagement there. When you are used to the carry guider and the 5 French, it's really very slick and with less trauma. And my goal is really to get where is the problem so I can coil it. Of course, it is impossible to coil it. It is impossible to send to Dr. Dube to do anything, ligation or anything like this. So what I'm going to do. So what I did here is really I went to the native artery and I just stented the native artery. And once I stented the native artery, I think that I probably solved the Steele phenomena. And you can see the difference here between both of them. So this is one before and one after. And you can see the competition coming from the distal LAD back so much in the first picture, but not after stenting. Now we move to EPDs. The last time I used EPDs maybe 2008. Okay, I know it's an important thing and many people there are in love with it. I don't think it's really needed if you are very careful. And if you want to use them, please try to use them carefully and never use them if you are stenting the ostium of the graft, because that can really trap the stent with it, and that will be a problem. So there is a no flow and there is a no reflow phenomenon. A no flow, when you inject after any intervention you do and you don't see a flow, then you're saying, what's happening? So you need to really rule out mechanical problems, spasm, dissection, or thrombus. And no reflow phenomenon, it's a different story. It's when you send all that junk, debris, down to the microvascular bed, and the blood is going to be stagnant, will not be really accepted by the muscular bed. That's a no reflow phenomenon, and this is the one that you have to treat with adenosine and calcium channel blockers. This is a case, a carry left guider. Usually when I want to engage to the grafts, I use a 3.5. It comes very short and can engage to them. I wire, and then after I wire, I balloon. So I ballooned the severe lesion in the mid segment there. Once I balloon, I anchor my guider because it wasn't really open very well. I anchor my guider with the balloon up, and I try to reposition my guider and push it a little bit inside. Now I can deliver my stent. I have a full, result without any problems or complications. Now we go to this case, which is a very nice case. This is a case that had a total occlusion of the graft. As you can see, there's an old stent in the center part of it. And this has been done about 6 to 8 weeks ago with one of my partners. So I came in, I wired, the wire went very smooth, easy. Then I thought, why the graft is closing and stent like in 6 to 8 weeks? I put my balloon down there, injected through the balloon, and I made, an explanation. Maybe it's a small territory, and we see that. When the graft is hooked to a very small territory, sometimes they don't do very well. So anyway, I committed myself to stent proximal, distal, mid, whatever it is, and I have a good result. But then, what you can see, I saw, which wasn't clear, there's a little switch there of the right where the artery is coming back. When that happened, I get a little excited, like maybe a lot of you would do, especially Basem here. So I went and said, okay, this is a CTO case, and this is what I should do. Then I went back and I went to, for a CTO of the RCA. I could not pass my wire across to the aorta, even with the balloon, support high up. So I came back with the balloon, I ballooned it, and now you can see that there is really a bigger territory to the PDA and posterior lateral branch. And what I did at this point, I said, okay, let's bring her in 2 weeks. Look at what happened just in 2 weeks. For a CTO, in 2 weeks, the graft that I worked in, it's all gone. Just in 2 weeks, it's all gone. And this is just to tell you that when you have a severe degenerative disease of the graft, just forget treating that venous graft. I know if it is an acute, you need to do it, get the flow done, but know that it's just a few months down the road. Most of them, they're going to come back. If not a few months, within a year, most of them, they're going to come back. So now I was able to really connect to the aorta. Once I did that, right radial, right Acadi, 5 French, wired from antegrade, and more ballooning, so there's a lot of dissection, stented, and with good results. Now, this is the most important case. This has happened just 3 weeks ago, and I was a grounding physician for the month of September. And then the next morning, grounding, the fellow was presenting to me, and I said, thank you, yes, this is the core of my case presentation. There is nothing better than this. Let's talk before about what should we do when you do the angiogram like this. So the first step you do, you wire, of course. You wire. After you wire, you take a balloon over the wire balloon, not a monorail balloon, not a short axis balloon, what they call balloon. Take it over the wire balloon, put it down to beyond the lesion, take the wire out. At this point, you give adenosine. I use cardizem. Some people do use different calcium channel blockers. I give full dose of adenosine, like a 96 microgram. I give about 2 milligrams of cardizem, push them there, push normal saline, maybe 2-3 syringes of normal saline after that, then rewire again. Pull your balloon, put it over there. The size of the balloon should be 1.5 to 2.0. Not a 2.5, not a 3.0, not a 4.0. Just a little bit of ballooning that you want. Why is that? After you balloon with a 2.0 balloon, then you bring your stent. The stent should be undersized, just a little bit undersized, and very long. Like for this one, maybe you need about 26 length of a stent. I'll bring a 38, and maybe I will bring my stent, maybe a 3.5 stent. 3.5 stent, 38, and I deploy my stent. Now I take an angiogram. Now I see if I have a little no reflow, then I give more adenosine, more cardizem. If I don't have it, then I'm done and I'm leaving. Well, was talking to one of the ladies earlier, the blonde person, the American, the great guy, Brad Pitt, handsome, and Angelina, whatever Jones, lady, crazy lady, she did this case, or he did this case, and they wired. The first thing they did what? First thing they did, they ballooned. They did not use pre-treatment, which is controversial. I do use pre-treatment before I do anything in the graft, meaning adenosine and cardizem. So she ballooned with a 3.0 balloon. That's a very large balloon for all that junk to be delivered down. She shouldn't, or he shouldn't do that. Now, after ballooning, they took a picture. Look at the difference. Before is better than after in terms of the flow to the coronary arteries. So you already created a no reflow phenomena. They gave, of course, now adenosine cardizem. There is still the same picture. This is after adenosine and cardizem. What they did next is the most must not to do, which is they really deploy the stent. You should not stent when you have a no reflow phenomenon. It's a common practice. It is a wrong practice, not even a controversial practice. You should not stent unless you have a flow. So what I'm going to do, if you have a no reflow phenomena, despite all the work that you've done by giving adenosine and giving cardizem or whatever calcium channel blocker you use, then you have to not stent, send the patient to the floor, bring the patient after 2 to 3 days. The graft will be open, you put your stent the same way how you treat them. Now what they did, they ballooned again. And by the way, they ballooned again, and ballooned again. And at the end, there is no flow, and that's the end of the story of this case. So BMS, DS are the same, no worries about them. I don't have BMS in my hospital at all, so we use all DS. They are good, both of them, but if you are here and you have a problem. Also another thing that I forgot to mention, dual antiplatelet therapy for grafts, it's probably 2 years better than 6 months or 1 year. So take-home message, always review films and plan ahead in any intervention that you want to do. Consider subclavian steal syndrome or intercostal or PA, fistulas. Give preference to the native coronary. Whenever you have a graft disease and it is degenerative, forget the graft. Just go after the native artery, CTO, whatever it is, just go. Even if you're using the graft itself to open the CTO like I showed you earlier. Avoid bulky graft treat. Liberal use of vasodilators pre and post therapy. Do not pre-dilate the lesion except by 1520 balloon. Do not post-dilate your stent. You're not looking for a perfect picture, looking for a perfect flow in the vein graft because it's going to be down anyway in a year or so. Then consider slightly underside and a longer stent, and then when there's no reflow, do not stent. Wait and bring them back in 2 days. If you want to use EPD, you're fine. I haven't used them for the last 12 years and there's nothing happened to me. Careful use of IVUS and OCT, as I mentioned earlier, and prolonged DAPT therapy, and thank you very much.
Thank you, Dr. Mehiar El-Hamdani, for this excellent talk. As I promised you, I'll give you extra time just to confirm. Now, the floor is to Dr. Adel Almontacer. Is an excellent friend of mine, distinguished cardiologist, interventional cardiologist. Dr. Almontacer, he will speak to us about thrombus management in STEMI patients with high clot burden. The floor is yours, Dr. Adel.
Assalamu alaikum. I'll talk about thrombus aspiration, mainly manual thrombus aspiration. I have nothing to disclose. The old guidelines from 2012 recommended that manual thrombus aspiration should be considered. It used to be a class 2A. And this was based on small trials and single-centered studies. It's too fast. The new guidelines from 2017 does not recommend routine manual aspiration. It's class 3. This was based on 2 trials, the TOTAL and TASTE trial. The TOTAL trial included about 10,000 patients, and the TASTE trial about 7,000 patients. That's too fast. The TOTAL trial was a randomized trial. Half of the patient had PCI only, and the other half had manual thrombus aspiration plus PCI. This was in a setting of a primary angioplasty for ST elevation MI. There was a high, about 70% retrieval of macroscopic thrombus. Nearly 80% of the patient had a high thrombus burden. However, the trial failed to show any improvement in cardiovascular death or in recurrent myocardial infarction, cardiogenic shock, or in class 4 heart failure after 1 year of follow-up. There was a tendency towards a higher rate of stroke in patients treated with manual thrombus aspiration. The TASTE trial showed the same thing. There was no difference in mortality, no difference in cardiac death, no difference in rehospitalization for MI, and no difference in stent thrombosis. About 30% of the patient had a high thrombus burden. So the ESC guidelines correctly recommended or discouraged the use of routine manual thrombus aspiration based on these two high-powered, large randomized trials, which was also confirmed by meta-analysis. However, in patients with a high thrombus burden, the use of thrombus aspiration was left to the discretion of the interventional cardiologist. So there was a tendency toward lower mortality. However, this was offset by the rate of strokes. I would like to present 3 cases in which I thought manual thrombus aspiration did help the patient. So this was a patient who came to us about 2 weeks ago. He's only 26. He was about to walk around for his, to stage for his ceremony, graduation ceremony. While about to walk out on the stage, he developed severe chest pain and was about to faint. So he went to a different hospital, diagnosed with MI, and he came to us 2 hours post his chest pain. His ECG, as you can see, showed anterior ST elevation myocardial infarction, and a quick echo showed akinesia in the anterior, in the LAD territory. So he's an active smoker, but he denies drug illicit abuse. There's no family history of ischemic heart disease, no family history of DVT or PE. He was loaded with aspirin, ticagrelol, and was transferred to the cath lab. So this was his coronary angiogram. As you can see, the left anterior descending artery is occluded at the beginning of the mid-segment. So I did what everyone would do, pass a wire, balloon, and hope this will restore flow. One of the disadvantages of ballooning in ST elevation MI, and one of the nightmares of interventional cardiologists, is that ballooning may send the thrombus down the artery, and then you get no reflow. As you can see, there was some flow. However, the distal vessel, there's no flow. You can see the LAD is occluded distally. So I would normally do the same thing, try to balloon, hope this will break the clot. I put a balloon there, but this did not help. The flow remained semi-zero flow. So even in the total and the TASTE trials, no flow is associated with a very poor outcome. So if you don't get the flow back, then your patient's not going to do good. So manual thrombus aspiration, which is not routinely recommended, I thought is highly recommended in this patient. So after several runs with a Hunter aspiration catheter, I aspirated the red clot plus white clot. And then the flow is better. Distally, it's not great. There may be a spasm, there may be some of the clot down, or there may be a lesion. So again, did the same thing, a small balloon 2.0, gentle ballooning, and the flow was back. There was the lesion left where the acute plaque rupture happened, so I stented that one. And this was the end result of this patient. Case number 2 is a 46-year-old gentleman who is a heavy smoker. He presented with severe chest pain. His ECG was in keeping with anterior ST elevation myocardial infarction. He was preloaded with aspirin and ticagrelol and was transferred immediately to the cath lab. His coronary angiogram showed acute occlusion of the LAD proximally. So wired, ballooned, same thing I normally do. And then there is some flow. The flow is not great. My balloon might be in the way. there may be a spasm, so I pulled the balloon back and gave some nitrate. Nitrate helped. However, there is a discrepancy between the proximal and the distal segment of the LAD. So I thought, and there is a lot of clot there as well. So, and there is a hint of a muscle bridge as well, post that septal branch, if you could see it. So I thought stenting here may not be the best idea, because as you know, if you stent a muscle bridge, you precipitate stent fracture, and that's associated with adverse outcomes to the stent. In addition, the discrepancy, I didn't like the discrepancy in this in the vessel size. There is an ectasia there. So again, manual thrombus aspiration helped here. And after several runs, I thought there may be some haziness still, but the vessel looked, ready to do something. So I used the drug-coated balloon here, 3020, inflated for 1 minute. And this is what I got. I brought the patient back 6 weeks, and he was doing very well. There's no remaining lesion. And I avoided stenting that I thought may not help this patient or may cause adverse outcomes. Case number 3 is a 60-year-old gentleman who was presented to a hospital in Sabha with infraposterior ST elevation myocardial infarction, who was given aspirin, Plavix, enoxaparin, and was advised to travel to Tripoli for further management. He presented to us one day post-onset of his chest pain, which has now largely settled. He's a heavy smoker, and he doesn't have any past medical history of note. His echo showed hypokinesia, so we thought this must be a viable territory still. Hypokinesia in the basal mid-segment of the infraposterior wall. We loaded him again with ticagrelol and took him to the cath lab. So, as we know, late presenters do develop high burden of clot. And this, what you could see in the circumflex artery, he's got a large burden of clot. And again, the vessel size, I didn't like it. I thought, you need a very large stent, and you may need a lot of post-dilatation, which with the large clot may cause you poor flow at the end. So this is his LAD, which doesn't have much of an issue. So after several runs with manual thrombus aspiration, aspirated red clot, and this was the result I got. So the hazens almost all settled. The patient did very well, and we brought him back again in 6 weeks, and we didn't need to stent this as well. So I thought in these 2 cases, manual thrombus aspiration gave a favorable outcomes to our patient. And again, we should not be using it routinely as the guideline states, but in selected patient, it could be a game changer and should be always available in your cath lab. Thank you for your attention.
Thank you very much, Dr. Adel, for this eminent and very nice presentation and sticking to the time. Our last speaker today will be Dr. Basem Elbarouni. He's an associate professor, Division of Cardiology, associate professor, University of Mountain at St. Patrick's Hospital in Canada. He will talk to us today about the high bleeding risk patient management of dual antiplatelet post-PCI.
Assalamu alaikum. These are my disclosures. So I'll start with the case. 85-year-old female presents with an anterior STEMI, undergoes primary PCI to her LED. Her hemoglobin is 109 and has moderate renal impairment. Her GFR is 45 millis per minute. So question to the audience. Is this patient a high bleeding risk patient, or HBR? Who says yes? Who says no? Lift your hand. If you say no, you say maybe. I don't know. ما كنتش منتبه. هذه شكلها. Okay. This is the second case. 53-year-old male with lateral STEMI. Frequent customer. زبون مستمر. عاجبه الكهذا. 2015 had bifurcation stenting of his LED and diagonal to angina. Came back a year later with stenosis in his diagonal stent, was treated with a drug-eluting balloon. 2017 came for a separate lesion altogether with PCI to his RCA. In 2020 had a repeat angiogram for circumspect indications, and there was no new changes. But now presents with a lateral STEMI. He was treated with TNK as he was far away from our hospital, then transferred to us. We found he had a thrombotic lesion in the diagonal stent. This far out from his original stent, it was felt that it was neoatherosclerosis, and a new stent was put in this diagonal. So, is this patient at high risk of recurrent ischemic events? Yes, no, maybe, I don't know. Everyone says yes. All right, good. So, dual antiplatelet therapy used to be easy. الحياة كانت سهلة. كانت عندنا plavix, clopidogrel, هذا هو. If you presented with ACS, that was an automatic subscription for 12 months of DAPT. If you had a drug-eluting stent, that was an automatic 12-month subscription to DAPT, along with Netflix. If you got a bare metal stent, then we'd probably do 3 months of DAPT. And that was it. Those were the rules. Easy. What's changed? Well, we now have more potent antiplatelet agents, prasugrel and ticagrelor. Bare metal stents have become obsolete. The last bare metal stent I put in was in 2016. I don't think we have them on the shelf. All right, the newer drug-eluting stents are safer, less thrombogenic than bare metal stents. So there's no reason to use a bare metal stent. Prolonged DAPT beyond 12 months has been shown in trials to reduce ischemic events. On the other hand, trials have shown that short DAPT has been shown to be safe with significant reduction in major bleeding. So this patient is not the same as that patient. So 12-month subscription, same for all, doesn't work. We have to balance the risk of ischemia with bleeding. All right, so once you've done your PCI and you're sitting down writing your decision, you need to provide directions to the treating cardiologist if you want to stick with prolonged DAPT or shortened DAPT. And that's usually very, not straightforward. I'm going to base a lot of my talk on the Canadian antiplatelet guidelines published in 2023. I was fortunate to be invited to be a co-author and on the secondary panel for these guidelines. We defined high bleeding risks based on the BARC HBR Circulation 2019 guidelines, defining what high bleeding risk is. You only needed one of those major criteria or 2 minor criteria to be labeled as high bleeding risk. And these are not hard to achieve. Age more than 75 years, automatically you have 1 minor criteria. A hemoglobin of 110 to 129 for men and 110 to 119 for women, and you're older than 75, you would be high bleeding risk. If your hemoglobin was less than 110, if you had moderate or severe thrombocytopenia with a platelet count of less than 100, those are on their own major criteria. If you are expected to use long-term anticoagulants, concomitant atrial fibrillation, that's a high bleeding risk patient. So these represent about 30 to 40% of our patients are treated with PCI. So it's a very, very common condition. The patient that I described is high bleeding risk. She has a hemoglobin of 109, age more than 75, EGFR less than 60. We recommended that we would recommend using short DAPT for 1 to 3 months rather than 6 to 12 months in patients at high bleeding risk who undergo PCI for ACS or elective PCI. We felt that the evidence and the current data did not differentiate between these two, nor was there any signal. So either are fine, with maintenance single antiplatelet therapy thereafter. And those patients who do not have any ischemic or bleeding events in the first month. We felt the recommendation was somewhat weak based on moderate quality of evidence. There's lots of trials, a couple of them that I'll show, that master DAPT. After 1 month of DAPT, they were switched to single antiplatelet therapy. I did not define what the dual antiplatelet therapy was, whether it was clopidogrel or ticagrelor. I did not define what the single antiplatelet therapy was. It could be clopidogrel, it could be ticagrelor, it could be just aspirin. All right? And the control arm had DAPT for 6 months. This included patients with ACS and with stable coronary artery disease. They showed that there was no evidence of any harm by stopping DAPT early, with a significant reduction in bleeding events. All right? Now, the trials were not powered to detect ischemic events. So we might be missing a small signal there. But overall, this signal has been quite obvious. We did a meta-analysis as part of the guidelines to look at the different trials. TICO-HBR, STOP-DAPT2, STOP-DAPT2 ACS, Twilight HBR, which randomized patients to ticagrelor for 3 months, and then, DAPT for 3 months, and then at 3 months stop DAPT. That was one of the earlier trials. And all of these show a clear signal that stopping DAPT early does not increase MACE, with a significant reduction in major bleeding. Now, with all this data, do we really we just stop aspirin and just use ticagrelor or clopidogrel as a single agent right off the bat? And there was one study looking at that, STOP-DAPT3, and there seemed to be a signal towards harm. So I think you still need DAPT for a short period of time. All right? And based on those evidence, our recommendation was that in a patient with high bleeding risk, it would make sense to de-escalate a minimum of 1 to 3 months of DAPT, whether it was ACS or if it was elective PCI. And then after that, just continue to SAPT. That would be, it could be either a P2Y12 inhibitor or it could just be aspirin. We felt that all the newer drug-eluting stent platform had good evidence that they would qualify for high bleeding risk reduction. And as such, we, for DAPT, short DAPT in patients with high bleeding risk, the BioFlow DAPT trial compared the biodegradable polymer stent, Biotronic, which has a polymer that is biodegradable, hoping that that would reduce the risk of bleeding compared to a designed sirolimus stent, and there was no difference. And if you look at the trials, most stents have single-arm studies so that they can achieve an indication for high bleeding risk. And as such, in our recommendations, we felt that all new drug-eluting stents would be suitable for short DAPT, without specifying one platform versus the other. So this patient that we talked, I think everyone said he has high risk of recurrent events, has multiple visits to the cath lab, has had previous bifurcation stenting, presents now with stent thrombosis causing a lateral STEMI, and has 2 layers of stent in the diagonal. So this is a patient where, on the other hand, he's young and is not a high bleeding risk patient. So the recommendations for the short DAPT might have to be modified in those who have a high risk of ischemic events or have complex PCI. You know, this is expert opinion. These are what we think is complex PCI patients where we might have to keep an eye on. That includes patients with bypass graft PCIs, use of atherectomy, CTO PCI, left main PCI where the risk of an adverse event or stent thrombosis would be catastrophic, bifurcation with 2 stents, long stents, multiple stents, or multiple vessels. So in these patients, there might be evidence for even prolonging that. The Pegasus trial compared patients who had prior interventions. After 12 months, they would be randomized to aspirin alone and placebo versus ticagrelor for up to 5 years. 60 milligrams or 90 milligrams. And they showed a significant reduction in clinical events, mostly driven by reduction in myocardial infarction, which is great, except it did come with a higher risk of bleeding. That includes, to me, major bleeding or minor bleeding, bleeding requiring transfusion, all the bleedings. The p-values are all significant. So there is a price to pay with prolonged DAPT in that situation. So based on that trial and the DAPT trial, that used prolonged DAPT with clopidogrel, our recommendation is that in patients with ACS, as long as you feel the bleeding risk is low, you could after you could extend the dual antiplatelet therapy to aspirin along with ticagrelor at 60 milligrams POBID, 60 milligrams hoping that that will come with a slightly lower risk of bleeding, or with aspirin and clopidogrel. There's not as much data for prasugrel, as such it's a weak recommendation. So in this patient, I actually recommended that he continues with aspirin and ticagrelor beyond the 1 year from his event, as he is someone who I'm more worried about ischemia as opposed to bleeding. So this is a case 3 that I'll finish with. 96-year-old male, high risk and STEMI. His angiogram shows severe bifurcation distal left main. I say decline for surgery, but really, you know, this is like at 96, no one's going to consider that. Has moderate renal impairment. Given his presentation, he was, you know, a good 96. He underwent PCI intra-aortic balloon pump support. Broad ablation was used. At some point in this procedure, had a DK crush PCI with good image-based, good final results. So this patient has a foot firmly in each world. He has high bleeding risk pictures. His age. He has impaired GFR. He has, on the other hand, this is also complex PCI. Back to the complex PCI. You had left main PCI, bifurcation PCI, calcium modification. What are our options? What are we going to do now? What am I going to recommend? So, DAPT for 1 year? Who votes for DAPT for a full year?
1 year.
DAPT for 6 months? 3 months? 1 month? I actually think 1 year is probably more than too much. You know, I think you need 1 year here. And 1 month, I agree, is too short. I recommended 6 months, based on balance there. I think beyond 6 months, your chances of, you know, stent healing endotheliation will be complete. On the other hand, if you continue with 1 year and a 96-year-old, I think you're really risking bleeding up there with reduced events. So, in conclusion, duration of DAPT post-PCI is an individualized patient decision that needs to balance patients' bleeding and ischemic risk. In high bleeding risk patients, DAPT for 1 to 3 months is sufficient. In patients with high ischemic risk, prolonged DAPT is reasonable. And thank you.
Dr. Basem, may I ask all the speakers to come to the stage? We have a very interesting, very complex PCI session. We talked about spontaneous dissection, large thrombus burden, MI, graft failure and stenosis, and end up with high thrombus lesions, what to do, and high bleeding risk. May I have first question to Dr. Adel? When you say about thrombus, you used thrombectomy for the patient with MI, 2 cases. What's the rule for stent for these cases? How you decide whether this patient will go for stent after thrombectomy or just thrombectomy without stenting? I find it very difficult sometimes to choose between them. I mean, if I leave the patient without a stent, there is some risk of black rupture and he may come back again. Should I leave it? So how will you make your decision about this?
I don't think there's a right answer for that. The people used to use OCT and there's evidence of plaque rupture, they will stent. However, I mainly base my decision on if there is a stenosis or not. Here I don't have OCT obviously, but the patient I had, I didn't put stents in, none of them came back. So I'm very satisfied. There's no remaining important stenosis. I don't stent. Anyone have a different?
You know, well, we don't have the leverage to bring people for, you know, looking again with angiograms. So this is the only problem. I probably share the same concerns. And maybe we're in a different environment. We do probably imaging if we can, or just stent. But it seems like it's working well for you, so I believe that's a good thing.
I think the second case you showed was an amazing case. I don't know that if I would be comfortable leaving that without a stent. Obviously, you brought him back and showed that that was absolutely the right decision for that patient. So great work there. Yeah.
Thank you very much for all of you guys. Excellent talks. Appreciate your time. Dr. Mehiar, I really impressed with your skills. It's really excellent skills. You go from the right side to the left side and you put the catheter deep in the lima. It's amazing. How do you do that from the right side? You have specific, I think, a catheter that you use. If you can tell us about your skills.
أول حاجة هي طبعا حدود. هي كل حاجة فيها حد. It's a persistence. That's what I'm trying to say. You just you put your mind into something. You have to start. You have to train yourself on it. And you just keep doing the same thing again and again until you master it. I'm using a peripheral wire. I do a lot of peripherals. So I have a lot of skills with peripherals. So I use a specific wire called regalia wire. Regalia wire, the tip of it is very hydrophilic, very nice, like any nice coronary wire. But then the shaft of it is really a very strong shaft. So what I do, I shape my wire. As I am, what I do, I put my carry right guider, which is shaped like a multi-purpose. It's a softer wire, 5 French. I put it just at the end of the subclavian artery, just before the lima. Then I'm going to shape my wire in a way that once I get from the subclavian, I'm diving into the lima. Once I'm there, I push my wire down. If it is very tortuous, I bring a balloon for support, put the balloon and get my wire down across the lesion. Once I'm across the lesion, now I can use the same balloon or bring another monorail balloon and I put it at the lesion. Now at that point, whether it's a vein graft or lima, at that point I anchor with the balloon up. I push my guider softly, slowly, push it down where it's now engaged. Now from there, trust me, it's no worries at all. From there you take your balloon out. Now you can deliver it. You can do rotablation. You can do whatever you want. There's no difference at that point. The key is how you get your wire through it. And the other one is that how carefully you do not mess up with the ostium and the proximal segment of the lima. After that, if I will show you another case, another time I'll send it to you. Using 5 French carry guiders, I have my guider in the RCA down to the PD. So I'm in the posterior distal branch. The whole guider is there. It's like using a guide extension. Actually, the size of the 5 French carry products is smaller than the 6 French guide extension. So why not?
Excellent. We're open for the audience. We have Dr. Abdulgani. You have the floor.
Very nice session. Thank you so much. I have a comment for Adel, one for Basem. For Adel, the STEMI with large clot burden. The practice now in the US is changing more toward aspiration if you have a large clot, because you don't want a balloon, as you said, you don't want a stent. And the issue with the trials that failed, the total trial and the other one that failed, because they're using the wrong device. They're using conventional manual thrombectomy, which led to failure of aspiration and also high risk of stroke. What we're doing in the US nowadays, maybe in Canada, I don't know, we're doing a Penumbra Catrix device, which is a mechanical aspiration. We are having great success. We're getting the clot out in 2 minutes once we see this Prox LED. And now there's a trial, so I think in the next 5 to 10 years it will become a routine business. Not mechanical thrombectomy, but mechanical with a different catheter. So have you seen that?
What we have here is obviously just manual thrombus aspiration. I agree that Penumbra is a continuous vacuum. So it aspirates a lot of clot. The risk of destabilization is much less. I think it's going to be a game changer in the future.
Yes, honestly, it saved me a lot of times, and I have no reflow with the first small balloon, and then I use Penumbra and clear the whole artery in no time. Question for Basem.
A lot recommending that you put the balloon straight away. If you see after you wire, you go straight away with your Penumbra and aspirate the clot and get out. Yeah.
Yes, the other question for Basem, if you want to stop DAPT on somebody with left main stent, as you know, left main stent thrombosis could be deadly, right? So that's the main concern. So all the operators, they keep 1 year, they keep sometimes DAPT for life. Have you used OCT to look for the stent opposition and stent, healing? And
I think if you're doing left main PCI, I mean, if it's available, you should be using imaging, right? And if you've got a good image result with apposition is one thing, but more importantly, stent expansion with good stent lumen. Like if you achieve a MSA of 12, 13, 14, after 6 months of that, you're not going to have stent thrombosis. If you're not happy with your stent result, there's a lot of calcification, your MSA is a bit limited, that might change my decision. But how many stent thromboses of the left main, we need tons of left main. Do we see? I think it's generally a quite safe procedure. The major problem with left main bifurcations is not the left main LED, it's the ostial circumflex, where we have problems. And that's mostly ISR, not thrombosis. So I feel very comfortable with 6 months of DAPT in that situation.
I agree with Basem. I think if you're going just left main straightforward with whatever you want to do, 6 months is more than enough. For 1 year, because you are having, or more than that, you have a bifurcation stenting, so that's a different story for the left main. If it is a bifurcation in the territory of the LD diagonal, you don't have to really subject it to a longer period.
Just to make sure that the audience, it's about preference and risk of bleeding. So it's preferred to be 1 year for all cases. But if there is higher, like this case, high risk of bleeding, so you can go low to 6 months.
Not in the guidelines. No.
6 months for left main.
It depends on what you're doing it. If it's for ACS and the patient has bleeding, is not a high bleeding risk patient, then.
No, what the guidelines say? Is it 6 months? Now the guidelines changed to 6 months?
So as I showed our guidelines, there is no mention of left main, etc. We left it vague intentionally, where we said in patients with complex PCI, you might consider prolonging DAPT. Our original recommendation was 3 months for stable coronary artery disease.
That's the point, yeah.
So prolonging DAPT, by prolonging DAPT, I mean going to 6 months, you've already prolonged it in patients with stable coronary artery disease, all right? If a patient has a non-STEMI, left main bifurcation PCI, and is not a high bleeding risk, I would definitely do 12 months of DAPT.
That's the point, yes. So still 12 months.
If a patient is coming with stable angina, has left main disease, undergoes PCI, and has high bleeding risk, I would go from doing my usual 3 months in that situation to 6 months. Now,
let me clarify one thing. The guidelines, is this an acute coronary syndrome, or this is just an elective PCI? If it is an acute coronary syndrome, you still find 12 months.
12 months.
Because of the non-STEMI. Because the old days of STEMI for 12 months is unrelated to using the stent or not, just a maze from the non-STEMI itself. Now the new guidelines, if there is no STEMI, you still really have to go for 12 months.
Exactly.
I'm not talking about the bleeding risk and everything. But if you are elective, 6 months is more than enough. And actually some people that are I do sometimes 3 months. Somebody going for surgery.
I have done it many times, 3 months. By the way, it's very safe. If it's not high risk of ischemic event and low risk, especially if there's high risk of bleeding. So you can go for 3 months easily, but you have to be careful for left main and bifurcation or complex many stents. You have to take it case by case. But still, just for the audience, not to go from here by 6 months. If you can extend it to 1 year, that's better. Otherwise, 6 months or even 3 months, select cases.
Yeah. But the bottom line is high bleeding risk patients are very common, like up to 40%. And in those cases, even in ACS, we recommend sticking to 3 months or 6 months in complex PCI.
Yeah, thanks guys for the NASCO talks. Basem, usually we do high-risk PCIs, as you said, all patients with atrial fibrillation, and anticoagulation comes into play. So what are you going to use as an antiplatelet, and for how long?
So a patient who has atrial fibrillation is on trip and is on an oral anticoagulant.
Yes, obviously.
So Absolutely, the wrong answer is prolonged triple therapy. That is the wrong answer. We know that. You only need to be on an oral anticoagulant and a P2Y12 inhibitor. The only decision that you have to make is how long are you going to keep the aspirin on? Okay? Is it going to be you need to have aspirin on board. So a patient comes in with an elective PCI and they're not on aspirin, I will load them on aspirin on the day. All right? If it's a hospital admission, I would usually tell them to continue the aspirin until they leave hospital. It takes 10 days for aspirin to go off. If it's a high complex PCI, then I'm thinking about 2 weeks to 4 weeks. And that's usually where I would stop. Very rarely I would go more than that. The data shows that the highest risk of bleeding is in that first 4 weeks. So usually I would rarely go more than 4 weeks, and I'd like to hear what my other colleagues would do in that situation.
I do agree, and so you have to really think about it this way: are you using warfarin or are you using what? If you're using warfarin, it's better. First 4 weeks triple therapy, then you go for dual therapy, warfarin and Tobactus, for example. If you're using Noir, nothing there. I personally just do Tobactus. I don't use Berlinda or Effian. This is my preference. There's nothing against them, but if I use Tobactus and Noir, I don't keep in those cases, and I'm okay. I don't have.
Yeah, I think I came across one Chinese study recently published. They're saying they use ticagrelor with NOACs from day one post-stenting, and they're doing well. I'm not sure.
Yeah, you can. I'm just a little chicken. So
it's not necessarily complex PCI, though. I'm not sure what kind of patients.
The trials that showed safety of a dual approach and dropping aspirin, the majority of the patients that were enrolled were on clopidogrel. There was a very small number of ticagrelor patients. So that's just why I personally would stick to clopidogrel, because I think it has the best safety evidence.
Dr. Mohamed Ehmaid.
By the time because the appendage closed, it will be 3 months already.
Thank you very much, guys, for your excellent presentations. My question to my schoolmate, Dr. Mehiar. What's your practice regarding dealing with stenosis in the anastomosis site in SVG native artery? What's your practice?
So in the anastomosis, you have to really think about timing. When did you diagnose that? So if that was just within the first 4 weeks, you probably should not really play with it. Give it some time, because most of the time it's an edema around the area. You just want to really study that again. But if it's very critical and it's early on after surgery, do not touch it. Leave it alone. Treat the native artery, because that can be a problematic. It can rupture actually, and that's really a disaster. So as you go, after 4 weeks, you can balloon. If you're happy angiographically, there is a chance it will hold very well for quite a good time. But if you sense that there could be a dissection, or you want to use IVUS or CT, whatever you want to use, CT will not be helpful there. IVUS might be better because of the angle of it. Then you're probably going to decide whether there is dissection or not by IVUS. If there is, you have to stent. If there isn't dissection, you leave it alone, and they do very well. Did I answer your question? Osteoarthritis, you treat it like anything else. I mean, again, any focal lesions in the graft, they are not degenerative. You go ahead and treat them. SVGN? That's what I'm saying. Any focal lesion, whether it's ostial or the mid or distal, any focal lesion in the graft, go ahead and treat them. Don't chase the native. When we say chase the native, we're talking about severe degenerative disease because of the debris. Osteal disease is treated like treating the left main or any other osteal disease. You just have to really bring the stent about 1 millimeter out and flare it, and that will be the case.
just the timing. I'm gonna have one more question, but to echo your answer, Dr. Mehiar, about the vein grafts. Time is important after surgery because the anastomosis is still fresh. The osteal lesion, Dr. Mohamed, if it's still new, you may open the suture and it will be a disaster.
Any fresh lesion, don't touch it.
Exactly. So you have to be careful, wait some time to make sure it healed. Dr. Mehiar, about the timing, sorry, about when to chase the native, because chasing the native is better than opening the graft. Can you comment?
Chasing the native is any time, and it's probably your best thing. It's very fun to do. If he can see a native that he can open after bypass, and there's a disease, forget the bypass. Go after the native, unless it's very focal. Okay, if it is anastomotic, even early on, sometimes it happens within 48 hours. They send you the case, you see it, it's a thrombosis. Don't worry about the thrombectomy or anything. Just if you can't treat the native well, treat the native and forget the graft. Or if you can't, then you do thrombectomy and see what happens. Then you call Adel, and Adel will revise that again.
Last question.
سؤال لدكتور محيار. How do you manage the competitive flow with vein graft?
What's that?
Competitive flow. When there is two sublot.
Yes. Oh, okay. So there are some people that you put a plug in it. Do not worry about that. Your native artery is stronger than the vein graft by far. And it's like we have عندك التوب كم في مع البومبا هو هذا البومبا بتغلب and it's gonna close in a few weeks. It's not gonna be there anymore. Don't worry about vein grafts, forget them, okay? And by the way, guys, if there is no lima, there is no bypass. Don't send any patient if you cannot put to the LOD. Everything can be done nowadays by CTOs.
Okay. Thank you very much. By this, we close the session.
Thank you
very much for everybody.
Thank you.
السلام عليكم دكاترة. إن شاء الله في المحاضرة بتاع البوست جرادويت تريننج تشالنجز ان ليبيا أعطاها دكتور إبراهيم بدر. الناس اللي بيسافروا اليوم إن شاء الله اللي بيطلعوا